Moving on to the next topic, may I call upon Dr. Soumya Nambiar, who works as a consultant pediatric ophthalmologist at Comtrust Eye Hospital. She had done her pediatric fellowship from Shankara Netralaya, Chennai.
So good morning, one and all. First of all, I would like to thank Dr. Lakshmi for having given me this opportunity. So how do we approach a case of a diplopia? So this is always, we wonder how do we go about when a patient comes to you with diplopia. So first of all, start with the history. You have to ask first what the patient is having, whether the diplopia is an issue for the patient, and only then you have to deal with it. Okay? So next we go and ask, what happens if you close either eye? Just see that you have to ask if the diplopia disappears when you close each of the eye. And which part of the field is the patient having trouble? Is the diplopia vertical, horizontal, or torsional? And is it variable or constant? So let's deal with each of this with certain cases. So I had a 60-year-old lady who came with a diplopia towards her left side, and this was present since 2 weeks. It was sudden in onset, constant, and horizontal. It was more for distance than near, and there was a history of diabetes mellitus. There was no pain associated with this. So you can see on covering of each of the eye, you can see that there's no movement in the left eye. The left eye abduction, abduction is limited, okay? And you can see that the movement in the left eye is also quite slow. So this is a clear-cut case of left lateral rectus palsy. So if there is a binocular diplopia, so I have covered each of the eye, asked her if the diplopia is reducing, okay? And then you can see that if it is a binocular diplopia, it will disappear. Now, supposedly it is a monocular diplopia. That is, it will persist with, when you close the eye which is affected or having some corneal problem or anterior segment issue, the diplopia will reduce. So in that case, how do you detect that it is a monocular diplopia? Simple pinhole test should treat that diplopia. So it means that it is monocular and it is not binocular, okay? So the things that you have to see when a diplopia case comes is at what level the lesions will be, whether it's supranuclear, nuclear, infranuclear, at the neuromuscular junction or at the muscle. So usually the supranuclear do not cause diplopia, so you have to think lower down. So if suppose you get a horizontal diplopia, you know that your target is only the horizontal muscles mainly, the medial rectus, the lateral rectus. Or it is at the neuromuscular junction, think of myasthenia. Or you think of the third and the sixth nerve which will supply the horizontal muscles. This is how you have to think. If suppose it is vertical, it has to be something to do with the vertical muscles. The superior rectus, the inferior rectus, the superior oblique and inferior oblique. So you know the nerves that is supplying these muscles, that is the third and the fourth. So you have to differentiate between the third and the fourth. Or it could be a problem with the neuromuscular junction again. Always look at the near-distant disparity. This you can detect with your cover test. Okay, so if at all you find that the diplopia, the disparity that is on cover test, the squint is more for distance. So you think in terms of lateral rectus. If you think that the problem is more for near and distance, the patient is orthophoric, then you go in thinking in terms that somewhere medial rectus somehow it has been affected, whether it's a nerve, the muscle per se. Always it is important to do the cover test in all gazes, in whichever you are suspected, which gaze, horizontal or vertical. And ductions and versions has to be separately checked. What do you mean by ductions is you close each eye and look for the movement. In versions, you do look for the movement of the both eyes simultaneously. And never to forget the saccades and the pursuits. So this, as I showed the case, it was a left lateral rectus palsy, and your diplopia charting will help in detecting whether the images on the left side, you can see the images on the left side is farther away when compared to the right-sided image. So you know that there's a problem on the left side. You can always do a Hess charting, but usually if you don't have a diplopia charting per se can help you to come to the conclusion. Then you have to see what is the etiology, what is the onset, is it sudden, is it gradual, is it variable. So in this case which we saw, it was a sudden onset, there was a history of diabetes mellitus, so think in favor of a vascular cause. So if suppose you have a patient who is more than 50 years, there is no malignancy, you can wait for 2 to 3 months, especially in this case of diabetes mellitus, uncontrolled diabetes mellitus, you can wait and see. If there is no improvement, then you go on to do an imaging. And if suppose less than 50 years, don't have any other systemic causes that is associated, immediate neuroimaging, but always write when you send to a radiologist that you have to focus on the course of the sixth nerve. Now here we have a second case. It's a 53-year-old man who presented with sudden onset drooping of the right eye since 2 weeks. There's associated pain, no comorbidities, diplopia in the left and down gaze, there is no variability. So here you can see that the patient has got a right eye ptosis, and there is a typical case, that is, there is elevation limitation. You can see depression is also limited and adduction is also limited here. So it's a third cranial nerve palsy. So how do you differentiate between, how do you look out if the fourth cranial nerve palsy is associated with it? You have to look for the intorsion that is present here. So you can see here that always when you do in the slit lamp, you have to focus on the vessel which is there in the superinasal aspect, and you can see the movement, which indicates intorsion is persisting, so fourth is okay. Then you go on to manage this, you do a blood test and a BP in case it is a ptosis with complete ophthalmoplegia and a pupillary sparing in more than 50 years. Suppose you have a ptosis and incomplete ophthalmoplegia less than 50 years, definitely you have to go in for imaging. In case it is dilated, poorly reactive, and pupil is complete or incomplete ophthalmoplegia with ptosis, you have to do a MRI or CTA. CTA helps in detecting smaller aneurysms. In case of dilated pupil, poorly reactive and no ophthalmoplegia, which is quite rare, it is usually seen in comatose patients. So the pearls that you have to take home is that in a partial third nerve palsy, a definite neuroimaging is required. Look for other neurological signs like ataxia and hemiplegia, and always remember that if there is an aberrant regeneration that is developed, neuroimaging is mandatory. Now in this 26-year-old male, so you can see in this case, he's got a right head tilt. Okay, so there is a history of trauma. Okay, so you in a case of a right head tilt with a history of trauma, you look at the movements that is there. So you can see that the there is an underaction of the right superior, there is underaction of the left superior oblique here. So therefore, there is a right head tilt. So you have to look at the lateral gazes as well as the head tilts that I'll be showing in the subsequent slides. So you can do a diplopia charting, and you can see that in the dextrodepression, the diplopia is increased. So Hess chart will show that there is a left superior oblique palsy. The chart which is having a smaller image is that of the paretic eye. A double Maddox rod is very useful in this case to detect if the other superior oblique palsy, there's a mass superior oblique palsy or not. So you can detect the amount of torsion. According to that, you can know whether it's a unilateral or a bilateral superior oblique palsy. So this case, you can see that here you can see there's a right superior oblique palsy, and this is to show the Belchowski's test. You can see the movements that is there. So here you're covering each of the eye in the primary position. Okay, so you can see that there's an right hypertropia. You do in the right gaze there's not much movement, but in the left gaze you can see there is a increase in the right hypertropia, R over L. And it is more, when you do the tilt also, you can just see that. Okay, so you can see here there is no much, in right head tilt there is this movement, in left head tilt there is no movement. Okay, so this is how you test for the Belchowski's test. Now this case was a 50-year-old man who came with a ptosis which was variable. So you can see that on doing an ice pack test, the ptosis reduced, and a fatigue test that was done, you see that there is an increase in the ptosis amount. So it's a case of myasthenia. So remember that myasthenia can masquerade as any condition. With any pupil sparing pattern of misalignment, you have to keep myasthenia as one of the differentials. Then this case was a boy who came with a history of injury with the elbow of his brother. So you can see that he came with a right face turn, and on correcting the posture, you can see that the left adduction is very much limited. So this was an avulsion of the medial rectus. Okay, that was because of the trauma. And always remember that with diplopia, you have to look at the associated signs as well, so like proptosis, like the lid signs. All these also have to be seen, especially this is the case of a thyroid ophthalmopathy. Here we have a 4-year-old child the mother brings the child saying that the child initially complained of diplopia, but subsequently she didn't have diplopia. But you can see that definitely there is a left exotropia here, okay? And on examining the fundus, I found a mild disc pallor in this child. And history-wise also the child had diplopia. So remember that in children, initially they may have diplopia, but once they develop a squint, they start developing suppression. So they will never complain of diplopia. So history is very important in this condition, and this turned out to be a craniopharyngioma for the child. Now this case was a case of acute non-accommodative esotropia. This is very common nowadays because of the increased screen time that we're seeing. Okay, and usually you'll have a committant kind of a squint in these cases. So here you can see the child has a right esotropia. And after operation, this was there since 2 years. So I operated and now he is diplopia free. This lady, she had a history of squinting since 2 years. There was a sudden onset again with diplopia. And she had a history of homocystinuria. And you can see that there is a adduction limitation in both lateral gazes. So this was a case of bilateral INO. I got an MRI done. MRI did not detect this thing, but homocystinuria was there. So since 2 years, she has been having diplopia. And I did a true muscle transplantation for her, and she is diplopia free now. Now remember, in diplopia, always look for these 6 P's: the pain, proptosis, progression, the pupil involvement, ptosis, and for the aberrant regeneration. So by this, you can come to the conclusion what it is. Thank you.
Thank you, Dr. Soumya, for that wonderful